In 1888, French physician Charles Ferret was studying the unusual skin of an anorexic patient. He measured the electrical signals from her skin using an apparatus known as a static electrical bath. Over the course of his investigations, Ferret discovered that when he presented his patient with frightening stimuli, the electrical conductance of her skin would increase. This finding eventually became known as the galvanic skin response, and it's still used in research today as an objective measure of emotions. Physiological measures like the galvanic skin response are really useful as an objective measure of a person's emotional state because, as the psychoanalysts found out, introspection and self-report are not always the most accurate or reliable ways to collect data. Yes, people can always lie about how scared or bored or in love they are, but strange as it may seem, people can also have a pretty limited insight into how they're feeling. For example, research suggests that people who struggle to regulate their emotions will also struggle to differentiate between similar emotions like anger versus frustration. These people are also at heightened risk of mental illness, so it's really important that psychologists understand this phenomenon. And this complication is just one of the many reasons why researchers collect objective physiological measures in addition to self-report, so that the two forms of data can be checked against each other. There are a number of techniques that can be used in combination to build up a more detailed picture of exactly how a person's body is responding to the experimental situation in real time. One of the techniques that measures a person's heartbeat is called electrocardiography, or ECG. There are two things that can be gained from ECG. One is heart rate, or the number of times that a person's heart beats per minute, and the other is heart rate variability. This is basically how heart rate changes over time and can be useful as a measure of how fast a person's emotions change over time. Another technique, facial electromyography, measures how different facial muscles activate and can be used as an objective measure of emotional expression. In the lectures next week on emotion, you'll see how these exact techniques have been used in research to help psychologists understand how we experience and express emotion. But sometimes even physiological measures aren't good enough. Sometimes we have to go deeper into a person's brain. Finding out what bits of the brain perform what function often uses neuroimaging. One of the techniques you might be familiar with is functional magnetic resonance imaging, or fMRI. This machine uses a really strong magnet to measure oxygen levels in the blood and build up a detailed picture of how the brain is working. What's really great about fMRI is that most machines also have a little TV screen inside them, so experimenters can show images or videos to the participant, and then the scanner can detect how the brain is responding to that video in real time. Most machines also have a keypad that the person can press without moving their head and blurring the image. What this means is that researchers can get participants to perform tasks like solving maths problems or reading comprehension, or pushing the right button if the face is happy, or pushing the left button if the face they see is sad, and not pushing any button if the face is neutral. The machine then tells the experimenter how the participant's brain activity changed depending on what they saw and their behavioural response. Now, it's important to remember that brain scan images essentially represent a correlation between the brain's response to seeing an image, say seeing a picture of a face, and the behavioural task that the participant has been asked to perform, say pushing the left button if they decide the face is sad. Because it's correlational, researchers need to be careful not to overstate their fMRI conclusions, because even if 1 million or 1 billion people's brains light up in exactly the same way when they correctly label sad faces, it still doesn't tell us if those parts of the brain were necessary and sufficient to make that decision and produce that behavioural response. This is a complex idea to get your head around, so a good analogy is thinking about how necessary and sufficient the hand is for writing. Now, millions of people use their hands for writing, but hands aren't necessary to perform this behaviour. Many people who don't have hands due to injury or birth defects are still able to write using other parts of the body, such as their mouth or feet. Likewise, hands in and of themselves are insufficient to perform the behaviour of writing. The hand needs to be able to move in a certain way, it needs to be able to grip the writing implement, and the person who owns that hand needs additional life experience, including knowledge of how and what to write. Just like this analogy, if we showed people angry faces and saw that the amygdala in the brain lights up, we couldn't conclude that the amygdala controls anger. Without doing more research, we wouldn't know if the amygdala was necessary for anger. Can people who have damage to their amygdala still feel anger? Likewise, we couldn't say that simply having this part of the brain is sufficient to enable a person to feel anger, because just like learning to write, we wouldn't know if other factors played a role, like hormones or life experience. This is why researchers need to run lots of follow-up studies and measure lots of different factors to tease apart the complex relationships between brain, behaviour, thoughts and emotions. To help researchers understand exactly what their physiological and neuroimaging data mean, they are often run in conjunction with self-report measures like surveys. Now, I know, I just said that self-report can be unreliable, but if our ECG results and our skin conductance results and our pupil dilation results and our fMRI results all say that the person is probably scared, and the person tells us that they're scared, then we can be pretty confident that the person is probably scared and that our fancy machines are building up a valid representation of how the body responds to fear. One of the good things about having multiple measures together is that we can build up a detailed picture of how a whole host of different variables relate to each other. And this is where self-report measures and correlational studies are really valuable. Carefully written and validated surveys allow researchers to obtain a standardized measure of a person's thoughts, feelings and experiences in different situations. They can then see how these physiological and psychological factors are influenced by things such as age, sex, gender, income or education. One of the techniques used to investigate how lots of different variables relate to each other is by analysing the effect of mediator variables. This analysis essentially looks at how the effect of variable A influences variable B via the effect of a third variable, which is called the mediator variable. To give you an example, we know that people with depression and anxiety tend to engage in more harmful drinking habits. Compared to the rest of the population, they also have a greater risk of developing alcohol use disorder. But why do we see this correlation? A recent study surveyed hundreds of university students at the beginning of the semester and the end of the semester. And they looked at whether the correlation between negative emotions and harmful drinking is mediated by the social context of the students drinking. What they found was that students who showed high levels of depression and anxiety at the beginning of the semester were more likely to drink alone. And it was this factor that predicted whether they went on to show harmful drinking habits and signs of alcohol use disorder at the end of the semester. What's really interesting is that if depressed or anxious students did happen to drink in a social group, this sociality had a protective effect, so they were less likely to develop harmful drinking habits than their anxious or depressed peers who drank alone. Now, it's all well and good to understand why certain disorders occur, but we need to keep our eyes on the prize. What we really want to do is treat the disorder. And this is where randomized control trials come in. Randomized control trials, or RCTs, are a special type of quasi-experiment designed to test how effective different treatments are. For new treatments to be considered effective, they must work better than a placebo and ideally be better, cheaper, or have fewer side effects than the current treatment options. So how do we run a randomized control trial? Well, first, participants with the specified mental illness are recruited. Unlike many other experiments, RCTs don't recruit people without that mental illness because there's no point in giving treatments to people who don't need treating. Participants are then randomly assigned to receive either the new treatment or the existing treatment, sometimes called the treatment as usual condition. RCTs often compare these results to some sort of control condition, either a placebo or a waiting list control. These controls are really important because placebo effects can often be quite large, and waiting list controls allow us to see when it's safe to just leave people alone and allow them to recover of their own accord. In the weeks to come, we'll be looking at research and treatment in much more detail, and we'll also see how all of these pieces of the puzzle fit together when we take a closer look at the psychological theories of emotion, cognition, fear, and mental illness.